live stream.
All right. Good evening and welcome to today's episode of PLAB-1 discussion class. All right. We're going to continue from where we stopped yesterday. And yesterday we stopped at central nervous system. All right. We're going to continue with that. Today, I'll be sharing my screen in a jiffy. All right. You're able to see my screen right now. Are you seeing it? Are you guys seeing it? No password involved. Can you see the screen? All right. So, Shara, did it tell you to enter password? Let me know whether Noya is on his own. Noya, you're on your own. Stopped at 9%, I think. I think we answered this question. This was the one that was frontal, cerebral angiography. The one that was telling long stories. All right, let's start from here. So we're in CNS now. I think the initial maybe 5 or 6 questions were wrongly categorized. You get, they were supposed to be psychiatry, but they were categorized as CNS. So recategorize those ones. But are you not seeing these questions? These are core cranial nervous system questions, right? So a 55-year-old chronic alcoholic with known hepatic cirrhosis has been on a heavy bout of alcohol the night before and was brought home by friends after falling several times in the pub, right? While being taken up the stairs to his bedroom, he falls down the flight of 5 steps but sustains no obvious injury. His wife calls the emergency department the next day because she could not rouse him in the morning. He's brought in comatose state and both pupils appear dilated. Skull vault X-ray appears normal. So what do you think is the diagnosis? Severe migraine attack, subarachnoid hemorrhage, acute subdural hematoma, vertebro-basilar ischemia, depressed skull fracture, chronic subdural hemorrhage, extradural hemorrhage, brainstem injury, intracerebral hematoma, hepatic encephalopathy. Chronic alcoholic with hepatic cirrhosis has been on a heavy bout of alcohol the night before, brought home by friends after falling several times in the pub. While being taken up the stairs to his bedroom, he falls down the flight of 5 steps, right? But sustains no obvious injury. His wife calls the ED because she could not arouse him in the morning. He's brought in comatose state. Both pupils appear dilated. Both pupils. There's no unilateral anything, all right? Skull vault X-ray appears normal. So there was no fracture, obvious skull fracture. So what do you think, guys? This guy, 5. Okay. I think it's hepatic encephalopathy. It's not. Don't you think with all these things, like he became unconscious after he fell? Something else could be happening. Acute subdural hematoma. That was a red herring. I think that's what they call this. Red herring. All these ones They want you to think of something, but they don't want you to think of something. But if you notice, it's not like he has been in coma before, or he has had anything like this before, or there was a gradual onset of, because hepatic encephalopathy is progressive, it's gradual, it's not sudden, right? So this patient had a fall. Following the fall, now lost consciousness. So he was conscious at least the day before, right? Even though he has been having bouts of binging of alcohol and all that, but he was conscious, okay? And probably he was tipsy, he was staggering before he fell and hit his head. Right? So even though score X-ray will not show you anything, right? That does not mean, and it does not show you anything means that there's no skull fracture, right? But subdural hematoma, because it's venous, the small, what do they call those veins inside the brain, right? When a person falls, especially someone that is middle aged, have to come back and check the age of it. One that is middle aged stroke elderly, right? When they fall down that way, you can start having a rupture some vessels, right? Usually a venous, okay. And when you do a brain CT scan, you may now see something. So it's called X-ray, will not show us anything. There's subdural hematoma. If there is epidural hematoma, maybe you may see evidence of fracture on the temporal side of the skull, all right? That's something that may guide you in dural hematoma. But for subdural, you will not see anything on the skull X-ray. There will be no obvious fracture because it's tiny veins, right? There's a lot of contusion, whiplash, right? Especially for an elderly patient or middle-aged who is beginning to have some form of cerebral atrophy, right? So subdural hematoma is a collection of blood, right? First of all, it's called subdural, so it is below the dura, unlike epidural that is outside the dura, okay, outside the dura mater. So collection of blood that forms in the subdural space between the dura mater and the arachnoid mater, all right? It can be classified as acute, less than 3 days after injury, subacute, 3 to 21 days, or chronic, more than 21. So you can see a patient coming that had a fall, especially in elderly. I had fall like some days, some many days ago, even weeks ago, right? Coming down and this, right? Water sensorium, loss of consciousness, coma. Okay. So, or as simple as no associated parenchymal injury versus complicated. Okay. Pathophysiology leading in a subdural hematoma occurs from tearing of the bridging veins. Thank you. This is the word bridging veins, right? So it's the bridging veins that cross from the cortex to the dural venous sinuses, okay, which are vulnerable to deceleration injury. So, there's acceleration, there's deceleration. So, deceleration is like when someone is falling, that's the they said with every action there is an equal and opposite reaction. So when the person falls, there's also some bouncing. Okay, that's contusion, that whiplash, right? So the veins, because the brain of middle-aged stroke elderly person has begun to atrophy, so there will be more space within the skull for all this deceleration injury and whiplash and all those things to occur, right? So in that vein, the the interconnecting veins, the bridging veins that connects the cortex to the dural venous sinuses will have more space to be able to tear. And once any of them tears, that's automatically subdural hematoma. All right. This subsequently leads to accumulation of blood in the dura and arachnoid space and results in a gradual rise in intracranial pressure. Gradual keyword. All right. This can lead to herniation and brainstem death, of course. And when you do a brain CT scan or brain MRI, you will see, what will you see? Because it is on subdura, that is under the dura, right? To spread along the dura, right? And now form this semilunar pattern. Okay, so if it is an acute subdural hematoma, you will see like white on brain CT, which is hyper dense, right? Okay, or in MRI, you say hyper intense. On brain CT scan, you say hyper dense, right? Then if it is chronic, right, you will see black, which implies that it has dissolved. And what happens is that the blood clots that were formed, that were initially white, hyperdense on brain CT scan, initially in the acute phase, will undergo lysis, all right? Lyse, they will dissolve, all right? That's when it now appears as hypodense, okay? Then the subacute will be isodense. There's no difference between it and normal brain parenchyma. Right? So risk factors. Majority usually blunt trauma. Majority of acute SH occur due to trauma. However, can occur in the absence of any trauma, commonly as chronic. Right? Risk factors for SDH include increasing age, like I mentioned, alcohol excess. So I think this was why they were giving you all those history. Alcohol excess is a big risk factor, and then increasing age, epileptics, because they are prone to falls, head injury, those with clotting disorders, or those taking any anticoagulants. So breathing veins are more vulnerable to tear due to brain atrophy and stretching of these veins, like I've explained to you guys. So this is subdural hematoma, classic subdural hematoma. Epidural will be more contained. So it forms this lentiform, this thing, or concave or convex lentiform appearance, okay, like the lens of the eye. But this one, semilunar, all right, spanning along, tracking along the dura mater, okay. Then intracranial gates, okay. So clinical features, altered level of consciousness, headaches, focal neurology, because of raised intracranial pressure, right, such as blood vision, worsening headache, or even seizure disorder, right? Clinical features of an acute SDH occur quickly, while those of chronic have a latent period, of course, over weeks, even months. Okay, so those chronic ones, the patient may even have forgotten that he had a fall, history of fall. But when he's an elderly person, you suspect it very well. All right. In children, it is important to survey other injuries. Differential diagnosis, was epidural hematoma is the differential, subdural hematoma, subarachnoid hemorrhage, strokes, that's intracranial hemorrhage, right? So all of them are even space occupying lesions, meningitis, encephalitis, dementia, but there is some things that will help you to differentiate which is which. Investigations, all these routine investigations, full blood count, ESR, but those are not the ones you do first. First thing you do is diagnostic investigations. That's investigations to make your diagnosis, which is brain CT scan or brain MRI. All right. So that's what, and you know that MRI has better tissue delineation than CT scan. CT scan has better bone delineation, and MRI has better tissue. So you see the brain tissue, visualize it better with an MRI than with brain CT scan. Okay, so you can now do other investigations, right? Early clotting profile, very important, right? Then looking at cosmetic. Gold standard initial imaging modality for a suspected SDH is a non-contrast CT scan of the head. SDH should show a crescent-shaped collection of blood over one hemisphere with or without associated midline shift. A skull plane film radiograph may be used in non-accidental injury workup in pediatrics. So temporal changes on CT imaging. Subdural hematomas will appear differently on CT imaging depending on the timing of presentation. Like I said, in acute phase, it will be hyperdense diffusely. In subacute phase, heterogeneously hyperdense or isodense. This is the word, isodense, all right? Then chronic subdural hematoma is diffusely hypodense. Okay? And acute on chronic subdural hematoma will present with areas of hyperdensity within a hypodense hematoma. That's acute on chronic. All right. So an example of the image. This is the bone. This is a CT scan because you can see the bone density, right? You can see the bone density being very, very clear. This is the scalp, right? This is the scalp, and this is the skull, right? And the bone density is very, very hyper dense. Okay. So you can see that brain density is said to be high, isodense, all right? But you can see that this density here is closer to density of the skull, right? Very close to the density of the skull. Density here. This is the density of the subdural hematoma, right? Right. Then you can see there's a midline shift of the brain structures. Look at it. This is supposed to be the midline, but there's a shift to the other side because of the obvious mass space occupying lesion here, right? Because when you see a patient in trauma, the first thing you should do A, B, C, D, E, okay? Airway, breathing, circulation, disability, and then E, exposure to see any other, whether there's any other thing going on, all right? And this patient will need, for management, this patient will need an um, urgent neurosurgery review and possibly neurosurgical operation, all right? What are they going to do? They're going to be based on size and on clinical features management. And conservative is generally appropriate for small acute subdural hematoma that do not cause significant midline shift or external encroachment without any significant neurologic impairment. For acute SDH requiring surgical intervention, a trauma craniotomy, right? So a craniotomy may be warranted. With a hemicraniectomy, there is significant cerebral swelling or associated contusions. For chronic SDH, surgical intervention can either be a borehole craniotomy with irrigation or twist drill craniotomy with brain placement. Okay, so using a drain has been shown to decrease recurrence rates, mortality without increasing complications. So complications of SDH. Complications following SDH includes cerebral edema, raised intracranial pressure, seizures, herniation, of course, PVS, persistent vegetative state, permanent neurological or cognitive defects, all right? And some people may have recurrent hematoma formation. So the 2 points, subdural hematoma is a collection of blood that forms between dura and arachnoid matter. Majority of SDH occur due to trauma, okay? Usually belongs to trauma. And if it's chronic, patient may not know. Patients can present with altered level of consciousness, headaches, neurological signs, features of raised ICP. Gold standard initial investigation is via non-contrast head CT scan, right? So that's comatose and both pupils are clear dilated. This patient is cone. Patient is close to death. You know that when a patient is about to die or when a patient is dead, you have this fixed dilated pupils, right? So this patient is coning because of raised intracranial pressure and patient needs urgent attention, right? An 84-year-old woman with Alzheimer's dementia. Eh, he has hepatic cirrhosis. That does not mean that he has a trauma in the head, that he will not have a subdural hematoma. The essence of painting those pictures for you was, one, to mislead you, because examiners can be wicked, but two, to tell you that alcohol is also a risk factor. All right, like you saw in what we just reviewed now, literature review. Yeah, some can intentionally mislead you. All right, so it's now left for yourself to, at some point, say, I'm coming down from this bus. I beg, I no go again. Let me find the appropriate bus. All right, so don't allow them to mislead you. So alcohol intake is a risk factor. Age is another risk factor. Trauma, risk factors. All right, and this person had five times. Was that not what they said? You're called 5 times, and after the last one, patient did not wake up again. Okay, so an 84-year-old woman with Alzheimer's dementia has recently become incontinent and more confused than usual. What is the single most likely diagnosis? Vagus nerve, um, glossopharyngeal nerve, lingual nerve, buccal nerve, facial nerve, vagus. Belle, your keyboard has started that thing is doing again. Well, I don't understand this question. 84-year-old woman with dementia, with Alzheimer's dementia, has recently become incontinent and more confused than usual. What is the single most likely disease? But this should not be the options now. What's going on here? Am I seeing a different question? Lingual. That's what they're saying now. What's lingual nerve? It's not nerve in the tongue. Or is my anatomy rusty? What does lingual nerve have to do with Alzheimer's disease that recently became confused? This is 70% of Alzheimer's who go on to suffer from incontinence issues. No, I think something was wrong with that question. So let's keep it. I'll figure out what went wrong. And 84, oh, this is the correct question. This is the correct question, right? Because the options of that question are not tying up with the question, right? So this is the correct question. An 84-year-old woman with Alzheimer's dementia has recently become incontinent and more confused than usual. What's the single most likely diagnosis? One, detrusor overactivity. Two, neuropathic bladder. Three, nocturnal enuresis. Four, UTI. Five, uterine prolapse. So what's going on? What's making her incontinent and confused? Incontinent and confused. It's a neuropathic bladder, nocturnal enuresis, UTI, recently, the UTI, like recent acute on chronic. If we are not catching these people's innuendo, I told you the CNS. CNS is something else, right? You have to just an open mind. They're dropping innuendos for you. This patient has Alzheimer's. The question they're asking, in fact, the answer is not related to Alzheimer's. So, this patient has Alzheimer's. That one is just there on its own, all right, and has recently become incontinent. So this is where the question started. Patient recently became incontinent and more confused than usual. See, in an elderly patient, when you see an elderly patient that is confused, look in their chest and look in their bowel, in their bladder, you will find the answer. An elderly patient that is confused. Elderly patient has UTI. They will not, no, elderly patient may not come with fever. You see an elderly patient that has core pneumonia, right? No fever. Or even if they have maybe low grade that you may not even notice. All right. So look in the chest, look in the bladder. You'll find something between those two. Right. So that's what's going on here. The key is UTI. In UTI, there may be incontinence of urine and confusion. You see? So that incontinence, all these answers, fine, all of them can cause incontinence, nocturnal enuresis, uterine prolapse, and neuropathic blood. They can all cause incontinence, but they cannot explain the confusion. So just pick out the things that are within the question and find out what's the common factor. HC, LCM or HCM? Highest common factor, yes, HCM. So a 38-year-old man with long-standing alcohol dependence, brought alcohol again, has vertigo and a tremor every morning. What's the single most likely diagnosis? Anxiety, benign positional vertigo, cerebellar degeneration, optic neuritis, temporal lobe epilepsy. He has alcohol dependence, then he has vertigo and what? Tremor. Vertigo and tremor every morning. So what do you think, guys? BPV. All right, you and this is your keypad. BPV. Why? Why do you think so? Why do you think it's BPV? Only in the morning. Okay. Well, okay. You're still explaining. Well done, man. Cerebellar degeneration. See now, does BPV cause tremor? I've told you guys now, connect your dots. Does BPV cause tremor? You're seeing two symptoms. I even highlighted them for you. Two symptoms. Vertigo and tremor. It's not only vertigo. So many of these answers can explain only vertigo. When they gave you vertigo and trauma and tremor as well. Cerebral lesions can cause tremor. All right. That was the only thing there that could cause tremor. It's CNS now. What do you expect? If brain no tough, wetin go come tough? The key is cerebral degeneration, chronic alcohol abuse, and there was something else too. Is alcohol a risk factor for BPV? That's what I was asking you guys. The most common cause of vertigo. Okay. The most common cause of vertigo, the sensation of spinning or swaying, causes a sudden sensation of paroxysmal positional vertigo. Symptoms: repeated periods of a spinning sensation with movement. Usual onset 50s to 70s. Look at the age of your patient now. Usual onset 50s to 70s. Why that patient was even like 30 something. Okay. Episodes less than 1 minute. Risk factors: older age, minor head injury. Diagnostic method: positive this whole pike test, right? Differential labyrinthitis, Meniere's disease, stroke, migraine. Treatment: there's some very early maneuver. Resolves in days to months, right? Let's see the symptoms. Symptoms are repeated brief periods of vertigo with movement, characterized by a spinning sensation upon changes in position. That's why it's called positional vertigo. So when you change position of the head, the person starts having the vertigo, right? And this can occur with turning in bed or changing position. So each episode of vertigo typically lasts less than 1 minute. So I agree with you that it can, like, someone is likely going to change position as soon as he wakes up from bed, right? Fine, that may happen, but that tremor cannot be explained by BPV. Each episode of vertigo usually lasts less than 1 minute. This is another clincher, less than 1 minute. Age is also a clincher. Nausea is commonly associated. It is one of the most common causes of vertigo. All right. Is a type of balance disorder along with labyrinthitis and Meniere's disease, right? Welcome, Dr. Sochi. You're welcome. It can result from a head injury or simply occur among those who are older. The specific cause is often not identified. When found, the underlying mechanism typically involves a small calcified otolite moving around loose in the inner ear. Diagnosis is typically made with Dick's Hall-Pike test, right? So, airplane maneuver, I wonder what it is. Positioning maneuver, okay. Positioning maneuver is a maneuver used by medical professionals to treat one common cause of BPV, right? So it works by allowing free floating particles from the affected semilunar bond. BPV is not a serious medical condition, but may present serious risks of injury through falling or other special disorientation induced accidents. So let me see. I just want to see the treatment, the airplane maneuver. Positioning maneuver, the airplane maneuver, right? Employs gravity to move the calcium crystal, because they said in the pathogenesis that it's calcium crystals are found within the inner ear, right? They are just dancing around. That's what causes it. So you now do this airplane maneuver, which employs gravity, all right, to move the calcium crystal build up that causes the condition. So this maneuver can be performed during a clinic visit by health professionals or people to perform at home, or both. Postural restriction after the airplane maneuver increases its effect somewhat. So when placed at home, the airplane maneuver is more effective than. Tell me how to do it. does not address the actual presence of the particles, rather it changes their location. Or okay, just like kind of hit a patient's head in one way. The maneuver aims to move these particles from some locations in the inner ear which cause symptoms such as vertigo and reposition them to where they do not cause these symptoms. So apparently there's another person's maneuver, Simmons. Maybe I'll have my own to George maneuver. All right. So many maneuvers. So let's maneuver out, continue our discussion. So a 32-year-old woman has had 3 episodes of slurred speech and 2 episodes of transient weakness of both legs in the past 5 years. Each episode has resolved in 3 months. What is the single most likely diagnosis? Now go here and for this CNS. Meningioma, migraine, multiple sclerosis, stroke, transient ischemic attack. The answer is very obvious. Three episodes of slurred speech, 2 episodes of transient weakness of both legs in the past 5 years. So it's a chronic condition. All right. No, yeah, doctor. No, yeah. Edon, sir. TIA. Yo, say so. Thank you, Dr. Shara. Lifesaver. It's multiple sclerosis. It's a very chronic. It's chronic. You know that multiple sclerosis is a demyelinating illness, right? So it takes a lot of time. It's just like this AML, AMS, amyotrophic lateral sclerosis that occurred to Stephen Hawking. Do you know Stephen Hawking? The professor of what now? The guy that came up with all these time travel theories and all those things. All right, Stephen Hawking. He died. Was it last year or last 2 years? Yeah, he died recently. Okay, so um, at a very young age, in fact, I saw a movie about him. At a very young age, around 25 or thereabouts, gradually, this guy was already a professor by that age. So he now started having gradual weakness. Okay, and that's how it occurs. Gradual. You can have this relapsing and relieving. There are 2 types, I think. There's one that is just progressively getting worse. Maybe progressing from maybe the lower limbs gradually coming up, even to the upper limbs, and you know, okay, even to the muscles of respiration and all that. The person will now require intubation and all that. That's what kills the patient is when there's respiratory and muscle affection, right? Then I think there's another time that does this relieving and relapsing and relieving onset, all right? So it comes and goes, comes and goes, comes and goes. And, another thing that will tell you that it's not a stroke or a TIA. This patient has bilateral, both legs, like paraplegia, right? Paraparesis, okay? Transient paraparesis. Is it transient that confused you? Sclerosis, also known as encephalomyelitis. Myelinated lesion can present with double vision, blindness in one eye. It can be related to neuritis, muscle weakness, trouble with sensation, trouble with coordination. So you can have motor, sensory, speech, everything, even the eyes, blindness. Age 20 to 50 years. How old is our patient? 32-year-old. So she's just in the middle of the peak age. Duration is long term, causes are unknown, and then based on symptoms and medical tests, that's diagnosis, right? And treatment, medication, physical therapy. I think corticosteroids has a role. See life expectancy, 5 to 10 years shorter life expectancy, okay, shorter than normal. So in Nigeria, where we have a life expectancy of 49, it means these patients then 30 something years. And abroad, they will still make it. So it is a demyelinating disease in which the insulating nerves, covers of the nerves in the brain and spinal cord are damaged. You know what the insulating covers are? Schwann cells, abi. So when the Schwann cells are damaged, you now begin to have the neurons not able to transmit impulses as fast as they normally do. Right? That's what causes all the symptoms you're having. Okay. And unless those Schwann cells regenerate, then there's an issue. Okay. So that's why corticosteroids do have a role. This damage disrupts the ability of the nervous system to transmit signals, resulting in a range of signs and symptoms, including physical, mental, sometimes psychiatric problems too. Specific symptoms can include double vision, blindness in one eye, muscle weakness, trouble with sensation, coordination. It can take several forms, with new symptoms either occurring in isolated attacks, that's the relapsing form, like this woman now had a relapsing form, or building up over time, progressive form. Okay, there's a relapsing form, like I mentioned earlier, then the progressive form, right? So between attacks, symptoms may disappear completely. However, permanent neurological problems often remain, especially as the disease advances. While the cause is unclear, the underlying mechanism is thought to be either destruction by the immune system or failure of the demyelinating cells. Okay? So factors include genetics, environmental factors, and even viral infection. But when they start saying factors include, that the cause is not known, it's idiopathic, right? But there may be some associated factors. There's no known cure for multiple sclerosis. So if you think HIV is the only thing that has no cure, there's so many of them. There's no known cure for improved and big function. Many evidence benefits, all right? It's an immune-mediated disorder. Immune disorder is a dysfunction of the immune system. These disorders can characterized by several different ways. Okay, it's hyperactive and there's underactive. So it's an immune-mediated disorder, not necessarily an autoimmune disease, but it's an immune-mediated disorder affecting the central nervous system. So it was first described by this person. The name multiple sclerosis refers to the numerous glial scars, right, or sclera. So multiple glia, the glial cells, essentially plaques or lesions that develop on the white matter of the brain and spinal cord. Number of new treatments. Okay. So I just wanted us to have that overview. Look at the symptoms: central, fatigue, cognitive impairment, depression, anxiety, unstable mood, visual, having nystagmus, optic neuritis. I mentioned, but that's one eye blindness or double vision. There are features of optic neuritis, and optic neuritis can be associated with multiple sclerosis. Then diplopia, that's double vision. Nystagmus, all right. Speech, you have dysarthria. Throat, you have dysphagia. Okay, everything. Muscle weakness, spasms, ataxia. Sensation, you have pain, hypoesthesias, paresthesias, all right? The bowel, you have incontinence, diarrhea, or constipation. So it's just a wicked disease. Urinary, you have incontinence, frequency, retention. So there's so much that could go wrong, and all of them will go wrong in the single patient. All right. So there's this Uthoff's phenomenon, which is a worsening of the symptoms due to exposure to higher than usual temperatures, and Lemmit's sign, an electrical sensation that runs down the back when bending the neck, are particularly characteristic of multiple sclerosis. Okay, so we are going to write on. At least we now have an idea. If someone tells you what's multiple sclerosis, at least you know that it's a demyelinating illness, okay, and is immune related, right? Autoimmune associated or immune associated disorder of the central nervous system. It is not an autoimmune disease, but it's immune associated, right? Demyelinating affects the glial. Then you can be able to list the symptoms from the head to the toe, from the eyes to the speech, okay, to swallowing, to the respiratory muscle weakness, to every other muscle weakness, to sensation. So motor, sensation, speech, everything, system, even urinary incontinence, even the GIT, right? So this next question is about a 6-year-old boy who has been noticed to have problems with coordinating his voluntary movements over the last 2 years. He has a waddling gait. Giving you the diagnosis. He has a waddling gait and needs to support himself on his hands when rising from the floor, right? He has larger calves than other boys, but he runs more slowly. Which is the most likely diagnosis? Myotonia, myasthenia gravis, Duchenne muscular dystrophy, muscular atrophy. What the diagnosis, guys? Should be done in about 30 minutes after rest. DMD. DMD. Duchenne muscular dystrophy. See the classical signs, all right? One is this waddling gait, okay? And then there's something called proximal myopathy, okay? First of all, he's a child. He's a child and he's a boy. I think it's commoner in males, all right? What kind of disease is DMD? I mean, in terms of genetic transmission, is it autosomal dominant? Is it autosomal recessive? Is it X-linked recessive? So apart from that, it's there's this proximal myopathy, and features of proximal myopathy is this child will need support before he can stand up, right? He cannot just stand up like you and I. Then if the child wants to raise the hands up, you have difficulty raising the hands up above the shoulder. So this child, for example, cannot comb his hair by himself, right? So, or he cannot keep something on the top of a shelf or pick something from the top of the shelf. So these are the issues with proximal myopathy. He cannot get up from a sitting position without supporting himself, right? So I asked you a question. What did I ask you? Waddling gait. Then he has larger calves than other boys. I asked you what kind of inheritance. You guys, even if you don't know, you give me okay. What if I forgot now? You not learn that one. It's X-linked. It's X-linked. You didn't hear what I said that it's more in males, right? I told you he's a boy. It's more in males. So it's X-linked. It's X-linked. And you know that X-linked disorders will, because males have only one X chromosome, okay? You know, males have X and Y, right? So X-linked disorders Women are usually carriers. That's the females in the family are usually carriers, and they transmit it to their sons or to 50% of their sons. Right? That's how it works. X-linked pattern. Right? X-linked recessive, just like hemophilia. What else is X-linked recessive? Hemophilia A, hemophilia B, ocular albinism. What else? X-linked. Color blindness. I thought you guys all these things now, or at least they are in the app. Internal medicine primaries. Okay, a 45-year-old man presents with a mass on the. Welcome. 45-year-old man presents with a mass on the right side of the face, right? The mass was first observed 3 months ago, but has recently become visibly larger. He feels pain over the mass and is unable to blow a whistle. Clinical examination shows that the mass is likely to be the parotid gland. An oral examination shows a foul-smelling discharge from the duct of the gland, and gentle probing shows that it is stenosed and the meatus. Which of the following features suggests that the mass might be malignant? Presence of pain, recent enlargement, facial nerve palsy, stenosed duct meatus. Guys, give me your answer now. Recent enlargement. Dr. Shara, what do you think? Dr. Bishop, are you still booting? We're in CNS, so boot fast. Stenosed duct meatus. Shara thinks it's stenosed duct meatus. Dr. Bishop is still booting. Dr. Shara, I think I agree with you. Recent enlargement, the mass has been growing for some time, right? It was first observed 3 months ago, but recently became enlarged. It recently became enlarged because there is a because there is obstruction, all right? Because there is stenosed duct, like the outflow tract of the duct, the parotid gland is obstructed. Well, I think that may be what would suggest that is a malignancy. But you may be right, Dr. You may be right. Recent enlargement. But facial nerve palsy. They mention facial nerve palsy in this thing. He feels pain over the mass and is unable to blow a whistle. Oh, okay. Unable to blow a whistle. That's facial nerve. These guys can suggest things. So unable to blow a whistle. That's facial nerve palsy. Yeah, you're probably right. You're probably right. Yeah, I think you're right. You're right. The key is C, facial nerve palsy due to malignant infiltration. Yeah. see suggestion, like out of all this big story, the only thing that suggested facial nerve palsy was unable to blow a whistle. That's it. And because, okay, so malignant parotid glands. All right, same question. A 50-year-old man with a known history of 50-year-old man with a known history of stroke is unable to get out of his house because he can't find where the door is. He refuses help from his wife and says he is not blind. What's the single most likely defect? 50-year-old man with a known history of stroke, unable to get out of his house because he cannot find where the door is. He refuses help from his wife and says he is not blind. What's the single most likely defect? Paracentral scotoma, tunnel vision, total blindness, central scotoma, cortical blindness. Has had stroke. Now he can't locate the door. Am I not being heard? Dr. Sarah, can you hear me? Okay. All right. So I think you're right, too. I think it's likely cortical blindness. Yeah, it is. And what happens in cortical blindness is different from, like, cortical blindness. The person feels that he can see because really he can see. I don't know how to put it, but he can see. His eyes can see, but his brain can't see. That's the easiest expression I can use for that. His eyes can see, but his brain can't see. You need your eyes to see. You need the nerves that connect your eyes to the brain to see. All right. And you need the brain as the cortical part of the brain, which is at the occipital region, right? The back of the head. You need that part to see. If anything happens to like if a person has a stroke in the cortical, like a person now supplies that region. Um, uh, Posterior cerebral artery, right? Posterior cerebral artery stroke. The classical feature is this cortical blindness. All right. So if perchance they change this question and ask you which artery is likely to have been affected, is posterior cerebral artery. Okay. So cortical blindness is a total or partial loss of vision in a normal appearing eye caused by damage to the brain's occipital cortex. Rarely, patients with acquired cortical blindness may have little or no insight that they have lost vision. Thank you. This is the word. If their eyes can see, but their brain cannot see, so they don't believe that they have lost their vision. They have little or no insight that they have lost vision. A phenomenon known as Anton Babinski syndrome. Everything get name for this word. Anton Babinski. Where else did we see Babinski? What's Babinski? Babinski sign. You're welcome, Dr. Agatha. Came close to closing time. All right. Where else did you see Babinski sign now? You guys remove this stuff. We're in neurology. Move neuro stuff. If you have your cardiology and your neurology, you are very strong in them. Seriously, no other thing will shake you. Primitive reflex. Babinski sign. Babinski sign. You're talking about primitive. Is it graph reflex? You're talking about Babinski. But you don't know what's Babinski sign. Fine. They did it. They do it in pediatrics. It's done in adults too. Yeah, yeah. There's some primitive something about it, but that's not the first thing I was expecting. Like, what's Babin's sister? Assignment for you guys. Oh, 76-year-old woman presents with deep stroke. No, Babinski sign. When you're examining the patient, now thank you, Dr. Sochi. You're doing neuro exam, and you use the tip of that your tendon hammer to scratch the. What do you think you are doing? You are looking for a sign, plantar response. That thing you do that time is called plantar response. All right. So if all the toes, normal response is flexor, flexor. All right, like the toes flex. That's normal response. But if the toes fan out, that's extend and fan out, and the big toe extends and the other toes fan out, that's called Babinski sign, right? A 76-year-old man presents with deep stroke 6 hours ago. What will be the immediate treatment? She has stroke 6 hours ago. What will you do for her? They didn't tell us the type of stroke. So from the things they are writing here, let's assume that it is ischemic stroke because of the age, right? The age suggests that it's an ischemic stroke. I think I've explained something like this before. Like ischemic stroke is likely to occur more in um, elderly patients, while hemorrhagic stroke, right, is likely to occur more in younger patients. Okay, and ischemic strokes have better prognosis than hemorrhagic strokes, depending on the size anyway. In general, okay? But even the level of consciousness is worse in hemorrhagic stroke. So, what do you think we should do? Hours ago, the immediate treatment: aspirin 75, aspirin 300, streptokinase, IV heparin. Have we discussed this kind of question before? Pyridamol. We discussed something like this in cardio. I think it's streptokinase. Why is it streptokinase? Streptokinase is supposed to be fibrinolytic. Okay. Thank you. I think it's about 2 hours is the cutoff. Yeah. Like for that streptokinase. Once it's beyond that, the risks outweigh the benefits. Yeah. So yes, thank you. If it's beyond that, if you do anything, you are likely to transform that stroke from ischemic to hemorrhagic, and which implies that the patient will now have a worse prognosis than he. What they say in medicine: first, do no harm. So you know this Sir Robert Hutchinson's prayer, right? Aphorisms. But what did he even say again? But yeah, like, let the cure of the disease not be more grievous than endurance of the same, right? So from that, let the good Lord deliver all of you, all of us. All right. A 34-year-old female presented with vomiting preceded by an occipital headache of acute onset. On examination, she was conscious and alert, photophobia, but no neck stiffness. CT scan was normal. What is the most appropriate further management? A 34-year-old female presented with vomiting, right, preceded by an occipital headache. Acute onset. She's conscious and alert with photophobia, but no neck stiffness. CT scan is normal. What's the most appropriate management? So what do you think is the diagnosis? What's going on here? What's the diagnosis, guys? This is the presentation of subarachnoid hemorrhage. That's what this patient likely has, right? With raised intracranial pressure because of this vomiting. They didn't tell us whether the headache is thunderclap anyway, but there's photophobia, but the patient is conscious and alert. But there must not be neck stiffness. There must not be neck stiffness in subarachnoid hemorrhage. It's plus or minus, but headache is always there. Usually it's thunderclap. It's described as the worst headache of her life. And the location of this headache too is classical for SAH. Usually occipital headache they have. And it's women. It's normally in females. Okay, young or middle-aged females, right? So she's conscious and alert with photophobia. Photophobia is also a feature too. The brain MRI. You can diagnose SAH from CSF. But do you think it's advisable? This exam are plus or minus. If because of this vomiting may suggest raised intracranial pressure. So I don't know whether it's advisable. But I think brain CT with contrast will show you the spider-like this thing. So if you just do a normal CT, you may not pick anything. But if you do with contrast, I think I'm just thinking out loud. So it's between this between contrast and CS that's raised intracranial pressure, having all those information and the types, then you just have to work with what we have. But contrast CT scan will show you the spider-like hyperdense depositions around the, what do you call it, in all the ventricles, right? And the systems, extension to the systems. So CSF exam. All right. So it's CSF exam. So probable subarachnoid hemorrhage. CT may not show any abnormality in early stage in some instances. And in that case, we shall do CSF examination 12 hours later to see xanthochromia. So CSF exam. So you have to do lumbar puncture. So it means that this vomiting is just like normal symptom because, like I was saying, the patient is conscious and alert. All right. So Vomiting with this one doesn't imply raised intracranial pressure. 63-year-old man with chronic schizophrenia presents with a mask-like face shape and involuntary pill rolling movements in both hands. He complains of chronic cough and forgetfulness. He is on long-term antipsychotic medications. What is the single most likely diagnosis? Side-Drager syndrome, Parkinsonism, autism scoria, tardive dyskinesia. The answer should already be obvious. Give me the answer. Yeah, so is this type of question you use and shine? Just know the answer, right? There are some that you have to crack. Okay. So my normal strategy now is that you should keep the ones that you have to crack first. Skip them. Go and finish the ones that you are picking in one glance, right? Pick up all those ones. Then you come back to the tough ones, the ones that need deliberation, the one that you need to call on your village people to assist you. And the gods of the land come to your aid. So, then two, antipsychotic drugs too suggested Parkinsonism because they can trigger Parkinsonism. Remember, it's one of the side effects because Parkinsonism is essentially dopaminergic fiber depletion, all right, in the substantia nigra of the brain, all right. So, when you're using antipsychotics, some of their effects, they they antagonize the dopamine channels, all right. D2. Bishop, your network is with your village people. A man brings his wife into the emergency department after finding her unconscious at home. He says at breakfast time she had complained of sudden severe headache. What is the most appropriate investigation? Sudden severe headache at breakfast time. Most appropriate investigation: MRI, CT scan, carotid Doppler, chest X-ray. Just found her unconscious. Okay. She had headache during breakfast, right? Then subsequently, she was now found unconscious. So I think a CT will do, Abi. All right. CT brain, probable SAH. Among the given options, most appropriate is CT brain. All right. A 56-year-old male who presented with epilepsy-like symptoms has been diagnosed with an intracranial space-occupying lesion. He now complains of taste and mild dehydration. His blood glucose is also increased. What's the single most appropriate immediate treatment? 56-year-old, epilepsy-like symptoms, has been diagnosed with intracranial SOL. Okay. He now complains of thirst and mild dehydration. His blood glucose is also increased. What's single most likely appropriate immediate treatment? Insulin, IV fluids, stop dexamethasone, stop sodium valproate, and change to another anti-epileptic. I think this thing is about side effects, medications or something. Any idea, guys? You said fluid. Hydration and tests. Elevated blood glucose. In the background of space occupying lesion. You do. Your neck and fluids, Abi. Your neck and fluids. Okay. You don't neck and fluids. You don't wear. The SOL don't dissolve. The answer is neck and fluids. An 82-year-old man, an 82-year-old woman has been admitted from a nursing home with dense hemiplegia and homonymous hemianopia. She is dysphasic. What vessel is most likely involved? I knew you are going to bring something like this. Admitted from a nursing home with dense hemiplegia, right? Hemiplegia, that's complete. And homonymous hemianopia is dysphasic. What vessel likely involved? Anterior cerebral artery, middle cerebral artery, posterior cerebral artery, internal carotid artery, inferior cerebral artery. Welcome to CNS, where you have to know neuroanatomy, neurophysiology, neuro everything. Guys, no answer, no attempt. You think it's posterior cerebral? Dr. Sochi, why do you think it's middle cerebral? Sarah, why do you think it's posterior cerebral? Dr. Agatha, you have not contributed anything today. You have not answered any question or attempted to answer a question today. You should attempt, you should be seen to attempt. You may not always be correct, but the learning class. If you don't attempt, you will not know what you don't know until you actually try. Right? Reason it out. We are all doctors. We are all about figuring things out. Nobody was born stuff. Even the father of medicine, Hippocrates, was not born with stuff. So who am I? Okay, so middle cerebral hemiplegia and not dysphagia. Dysphagia and dysphasia are two different things. Non-dominant hemisphere. How did you know it's non-dominant hemisphere? Did they say anything about? Don't they set their own question? No? How did you know it was non-dominant hemisphere? But I believe you. I agree with you. That's the middle cerebral artery territory. And middle cerebral artery is incidentally the commonest artery that is affected by CVAs. You guys are aware? Yeah, that's the commonest. commonest, is the artery most likely to have a CVA? The cerebral artery. I don't know why. So, Dr. Chara, I know this was what confused you, homonymous hemianopia. You don't have to be confused. This is homonymous hemianopia, not cortical blindness. All right? Not, you have to remember your visual pathway. All right? There's a part of it that passes through the temporal lobe. And we know that the temporal lobe is also involved in speech relation, right? That's there are two types of aphasia. There's expressive aphasia, like motor aphasia, where the person understands but cannot express himself. Then there's mcqs aphasia, right? Right? But just give us an idea. This patient has dysphagia, usually in posterior cerebral artery territory. You will not have dysphagia. There's no reason to have dysphagia because the speech center is not in the occipital lobe. What is in the occipital lobe is the visual center, right? Visual cortex. So the speech center is in around the temporal lobe. Okay. So all these things are what of suggesting the answer. So let me give you guys something to chew on. So let's learn something. The use of different methods of teaching.
In this video, we're going to look at the anatomy of the brain. We're going to firstly look at the basic anatomy, really simple, and then we'll look at the artery, the arterial supply, blood supply to the brain. So here we're looking at the lateral view of the brain. The cerebral hemispheres originates from the telencephalon. This is embryology. We have four main lobes, the frontal, parietal, temporal, and occipital. Then you have the cerebellum, which is part of the metencephalon. The pons is also part of the metencephalon. And again, the telencephalon and metencephalon are just terminology names used to explain where these structures originate in terms of embryology. Now let us take a sagittal section of the brain and see what anatomical structures are important to note. So remember, this was a telencephalon, which was your cerebral cortexes. Then you have the cerebellum, which is your metencephalon, together with your pons, remember? The brainstem is made up of three sections. From the top to the bottom is the midbrain, the pons, and the medulla oblongata. Within the center here of the cut brain, there is the thalamus, the relay station of the brain. Below the thalamus is the hypothalamus. Hypo as in below. So hypothalamus, below the thalamus. And below the hypothalamus, there are two lobes, and these are known as the pituitary lobes. The hypothalamus and the pituitary lobes, or glands, are important endocrine glands. Now let us look at the brain from an inferior view. So the inferior view of the brain, you can see the telencephalon, your cerebral cortex, and you can see the frontal lobe here and the temporal lobes on the brain. Below the thalamus is the hypothalamus. Hypo as in below. So hypothalamus, below the thalamus. And below the hypothalamus, there are two lobes, and these are known as the pituitary lobes. The hypothalamus and the pituitary lobes, or glands, are important endocrine glands. Now let us look at the brain from an inferior view. So hypothalamus. But this time, look at the arterial supply of the brain. So crawling up the brainstem, you have the vertebral arteries. Two of them which come from the subclavian artery. These vertebral arteries join to form the basilar artery, and the basilar arteries continue to crawl up the brainstem, up the pons and midbrain before basically bifurcating. And this bifurcation will form a circle around this region. This circle is known as the circle of Willis. The circle of Willis gives off a few branches: the posterior cerebral, the middle cerebral, and the anterior cerebral artery. Joining the anterior cerebral arteries is the anterior communicating artery, because it's the communication between the anterior cerebral arteries. And joining the middle and posterior cerebral arteries is the posterior communicating arteries. There are another two important arteries that help form the circle. Arteries continue to crawl up the brainstem, up the pons and midbrain before basically bifurcating. And this bifurcation will form a circle of Willis gives off a few branches. Let us now look at the circle of Willis again, but separately from the brain, just by itself. Again, here are your vertebral arteries which form the basilar artery from the back of the brain. And it will crawl up the brainstem and then branch to give rise essentially to the circle of Willis together with the internal carotid. But essentially, the basilar arteries branch, they bifurcate, giving off the posterior cerebral. Then you have the middle cerebral, which supplies the center of the brain. And here you have the anterior cerebral artery, which supplies the front of the brain. The anterior cerebral are connected to each other by the anterior communicating artery. And here is your posterior communicating artery. The internal carotid artery comes straight here and joins to the circle of Willis. And that is your circle of Willis, the round structure, and it has variations, of course. And these are the main arteries found in the circle of Willis. Now let us use this information we just learned about the cerebral arteries and talk about some clinical stuff. So stroke is a serious condition. Stroke is where we have interruption of blood flow to the brain or the brainstem for more than 24 hours. There's a terminology known as transient ischemic attack, TIA, and this is essentially when we have interruption of blood flow to the brain less than 24 hours. Stroke and TIA are life-threatening. 24 hours. Stroke and TIA are life-threatening. Distinguish between two types of stroke: hemorrhagic and ischemic stroke. If it's an ischemic stroke, thrombolytic therapy has to be initiated as soon as possible. Now let's talk about these two types of strokes: ischemic stroke and hemorrhagic stroke. Here I'm cutting a coronal section of the brain. In red are your cerebral arteries. Here is your middle cerebral artery we're zooming into, and this is your internal carotid that joins to the circle of Willis, forms the circle of Willis. Let's first talk about ischemic stroke. So ischemic stroke, an example of ischemic stroke is where we have a plaque formation in the internal carotid, which can lead to a potential stroke, or the plaque can rupture. It can rupture, creating a thrombus. Thrombus results in an emboli. The emboli then will travel up to the brain. And remember, this is the internal carotid. So the internal carotid will travel up to the brain, to the circle of Willis, and actually go to the middle cerebral artery, because the internal carotid is the main, it forms essentially the middle cerebral artery. So here we have the emboli. And the emboli, the thrombus, lodges in the cerebral artery. resulting in an ischemic stroke. The second type of stroke is the hemorrhagic stroke. Hemorrhagic stroke, a hemorrhage, is essentially when we have the rupturing of the vessel, blood spilling everywhere. So zooming into this middle cerebral artery, we have the rupture of the vessel because, for example, the vessel has an aneurysm and it just grows until it ruptures. So that is hemorrhagic stroke. Hemorrhagic stroke usually occurs in the anterior cerebral communicating arteries, posterior cerebral communicating arteries, and branches of the middle cerebral and basilar arteries. So that was just a quick overview on the stroke. Thank you for watching. I hope you enjoyed this video. Bye.
All right, guys. I want to believe you are touched by the above presentation. Right, so we move. There was something I wanted to show you. I don't think it was highlighted. That's the different kinds of lesions with each territory, like I explained. Like if you have an anterior cerebral artery territory lesion, you expect that the patient will have more of lower limb affectation, because there's something called homunculus, how the different structures are arranged on the brain, right? So when you have an anterior cerebral artery hemorrhage or stroke, okay, you expect to have more of the lower limbs affectation, like lower limb weakness, right? When you have middle cerebral, you expect to have more of speech, have more of upper limb than lower limb, and you have as well, right? Then when you have uh, posterior cerebral artery, you expect to have sensations with visual loss, all right? Blind cortical occipital lesion. Okay. 71-year-old man with no previous immediate history is brought to the emergency department by his wife, who said he has become progressively more forgetful, tends to lose his temper, and is emotionally labile. There is no history of infectious disease or trauma. What's the single most likely diagnosis? Fixed dementia, frontotemporal dementia, Huntington's disease, Alzheimer's disease, vascular dementia. Keyword progressively. All these other things tends to lose temper, that's aggressive behavior, emotional lability. All of them are associations of the same diagnosis. What's your diagnosis, guy? Memory loss, progressive memory loss. Be ending in a minute. So I think this may be our last question tonight. What's FTD? Frontotemporal dementia. Alzheimer's. It looks like Alzheimer's anyway, but your submission on that's Dr. Sochi's submission on frontotemporal dementia also makes sense because some of these symptoms, especially memory loss, is a frontal lobe lesion, but these symptoms, emotional lability, aggressive behavior, right, behavioral changes, they are in keeping with frontal lobe disease. But that word progressively, the Alzheimer's, progressive, at frontal lobe, frontotemporal regions. Not lesions, like temporal dementia. Umbrella term for a group of common brain disorders that primarily affect the frontal and temporal lobes of the brain. These are generally associated with personality, behavior, and language issues. You painted a picture of both. Let's. I think the keyword was progressive. Brain MRI of a 65-year-old. What is it? How old is it? 70. 70. Because of the age. Because of the age, it's likely Alzheimer's. So frontotemporal dementia or frontotemporal neurocognitive disorder passes several types of dementia involving frontal and temporal lobes. FTDs are broadly presented as behavioral or language disorders. Variance, Peace disease, blah, blah, blah. What I want to see is the symptoms. Behavioral, semantic, progressive, non-fluent aphasia. An early onset disorder that occurs was the issue, but can be earlier or later. The gradual onset and progression of changes in behavior or language deficits are reported to have begun several years prior to presentation. FTD is traditionally difficult to diagnose due to the diverse nature of associated symptoms. So they classify them into three groups: frontal, temporal, behavioral, semantic. Right. So behavioral variants, by changes in social behavior and conduct with loss of social awareness and poor impulse control and social disinhibition. Semantic, characterized by a loss of semantic understanding, resulting in impaired word comprehension. However, speech remains fluent and grammatical. Progressive non-fluent aphasia, characterized by progressive difficulties in speech production. Other characteristics: perception, spatial skills, memory, praxis. Binge eating habits, often associated with changes in food preferences, craving for more sweets, eating inedible objects, and snatching food from others. This is interesting. All right. In rare cases, can occur in people with ALS. Genetics. A higher proportion of FTD cases seem to have familiar components than more common neurodegenerative diseases like Alzheimer's. Let's look at Alzheimer's. Comparison of a normal aged brain, and the brain of a person with Alzheimer's on the right. It's done atrophy finish. See the size differences in size. Normal brain, Alzheimer's brain. so much atrophy, and widening of the ventricular spaces. So the ventricles so wide, and there's deepening of sulci and flattening of gyri. Okay, right. Factor genetic head injury, depression, hypertension. Usual onset over 65 years old, whereas we saw that in FTD they are usually less than 65. All right. So this is for elderly disease. For elderly. The neurodegenerative disease that usually starts slowly and gradually worsens over time. So it's progressive. The most common early symptom is difficulty in remembering recent events. As the disease advances, symptoms can include problems with language, disorientation, mood swings, loss of motivation, right? Behavioral issues. Patient's condition declines, they often withdraw from family and society. Gradually, bodily functions are lost, ultimately leading to death. Although the speed of progression can vary, typical life expectancy following diagnosis is 3 to 9 years. The cause of Alzheimer's disease is poorly understood, but 7% of the risk is believed to be inherited from a person's parents. Head injuries, depression, hypertension, neurofibrillary tangles, pathogenesis. Okay. All right. Last question. 54-year-old man has collapsed suddenly following a headache. He has hypertension and takes warfarin for prosthetic heart valve. DCS is 4 and dilated left pupil. What is the single most likely diagnosis? Disease. Anterior circulation stroke, posterior circulation stroke, intracerebral hemorrhage, pontine hemorrhage. Collapsed following a headache. He's hypertensive and he's 54. Takes warfarin for prosthetic heart valve. Yes, of 4. Likely a hemorrhagic CVA. Dilated left pupil. Or single most likely diagnosis. Why do you think of why are you thinking of pontine? What's your why are you thinking of pontine CVA? What's the rationale behind pontine CVA? Collapse. That it. Dilated left pupil. Anyway, not this one, it's not this one. It just be a normal intracerebral hemorrhage. Dilated left pupil does it really point to points? Anyway, we have many persons chose points. Yeah, Bishop. The entire shows ICH. Who is missing? Agatha. Agatha not contribute. It's ICH. All right. Cerebral hemorrhage, headache, collapse, warfarin use makes the diagnosis of intracerebral hemorrhage most likely. Pointers, bleeding, right? Meningism, severe headache, and coma within hours. Right? It just has a stroke. There's no, you don't have enough information to localize the stroke. Like all this anterior circulation, posterior circulation, she has a hemorrhagic stroke. So you don't have enough information to be able to say this is the territory where it's coming from. Right. So on that note, guys, we're able to get 20% all the way from 9%. So done a good job. Let's go and consolidate on CPA stroke. What you should do, just open your app. You're already in the app. Open Samsung's notes, right? Go to CNS, Central Nervous System. Read stroke, all right? Read there. It has a very it's short, but at least with all the things that we've talked about, let that one give you some structure. And I just read as much as you can from CBS, but read stroke first. All right. So catch you guys tomorrow. I'm already tired. Had a busy day. I had to keep this appointment. I'm going to end my live stream. Yes, you guys are doing well. Thank you for coming around.